And this is a little introduction to my philosophy. What's neat about the face, among many things, is that it's very complex. It takes many different developmental genes to form a face. And even though you look at the face as a single structure, it's very complex. And recognizing people is fairly easy for such a complex structure, because you can look at someone and know what they look like, and you haven't tried to pick out what their nose looked like, chin looked like, ears looked like. You just imprinted it. It's one of the easiest ways to learn and to remember. A lot of the other things aren't that easy with other parts of the body, but the face you can imprint primarily because we identify with people via their face primarily. And so we pay more attention to facial features as a form of identification. And when you look at syndromes, they have patterns that are repetitive, but they vary in the degree with which they're present and with the degree with which they express themselves. So there's a lot to know about the face in its complexity, but it is extremely useful. And probably 60% of the syndromes of multiple congenital anomaly syndromes has a reproductive face to allow you to make or suspect a diagnosis before you know anything else about the patient. So don't try to remember individual features as much as your Gestalt, but at the same time be able to dissect that Gestalt and know which features are actually contributing to the phenotype or the phenotype of the individual that will hold you in good stead and will keep you interested. There's no boring faces, I can tell you that. And when you talk about children with malformations, they're even more interesting. I've divided up the face into regions, and we'll go through these regions one at a time, and I'll give you some examples of each of these regions as far in using the frequency with which they occur as a good takeoff point to talk about each of the regions. You can see, well, this doesn't look too difficult. I know what a forehead is. Well, do you? Maybe, maybe not. The forehead is very complex and requires many different things going on for it to form normally. And you always have to remember, when you're talking about the face and abnormalities, the wide range of normal. Look at all your friends and their children and their children's children and their ages and everything of that nature, how the face changes, how it looks a certain way at a certain time, and many times later in life, or with weight gain, or with weight loss, or with many other things, the face changes. And when you're talking about syndromes, you have to be aware of what you're looking at and how that may have altered the phenotype from when it originally started out. That's why it's important to always look at siblings or their pictures. Always look at parents in their pictures. Look at the parents' pictures when they were young at the same age of the patient that you're involved with. That will often totally surprise you as to how much change from what you're looking at that point in time in, let's say, parents, as to what they actually look like when they were a baby, a toddler, a teenager, and then young adult. Now, this is what I see when I see a face, and everybody likes this because it looks like a robot, sort of. But each of these areas that I've put on this slide, this is the forehead, this is the nose, and there's a little area here I've put a hash mark called the glabella, which is a juncture of the forehead and the base of the nose. Then we have the eyes, we have the philtrum, we have the mouth, we have the mandible, we have the neck, and we have the ears. Now, each of these structures contribute to the facial gestalt to some degree more than others, depending on how abnormal they are. But if you look at these people with these sections in mind, when you're describing someone's face, then you can break it down pretty easily and describe it individually, and then it's additive to a gestalt of the face. The forehead, primarily we're interested in the height, vertical height, the width, the prominence, the recession, if there is any, and the symmetry. You could think, well, this doesn't sound very complex, but it really is, because a lot of structures, including the skin and the bony structure underneath and the anterior brain development, the skin itself, and any overgrowth or undergrowth of the facial structure will result in facial asymmetry. Now, none of us are perfect. The only ones that are perfect are selling their appearances on women's magazines and that type of thing. And actually, they're more abnormal because they have either good symmetry or very unique asymmetry that makes them very attractive for one reason or another. The forehead, this area here, is dependent on the things that we've talked about so far, but you can use the term 1/3 and use it to decide if the forehead is normal, short, or long. Here you see an individual who has fairly severe microcephaly. Many of the patients you see won't have this degree of undergrowth of the frontal part of the brain, which is the most common form. But the forehead normally occupies 1/3 of the vertical distance of the face, and here's where it normally would fall, normally would fall, normally would fall down here. So all the white area is where the normal length of the face would be judged. And you can see this individual's forehead, by using the 1/3 rule, only comes down to here, giving you a good indication that it is short. This particular child who has Crouzon's disease has a high forehead, which is also sometimes prominent, which you'll see in later photographs. And you can see that the white area down to here represents the normal 1/3 rule. But his forehead, judging this distance, actually comes down to here at the bottom 1/3. So his is clearly a high forehead. What difference does this make? Sometimes it doesn't make any. Some people have high foreheads that are normal. And in syndromes, you can use that to suspect maybe there's an abnormality. If it's different from the parents, siblings, regardless of these measurements, it's going to be put in the abnormal class until you prove otherwise. Here's a child with a prominent forehead. This child has Burke Syndrome, acrocephalosynactally, with the mitten fusion of the fingers. And they typically have a prominent forehead. And if you would turn this child sideways or have a lateral view, you'd see the prominence much better. But you can suspect it's prominent. One, it sort of looks prominent. Two, note the fold here. When the forehead becomes prominent, it forces the skin to envelop itself. And so you get a crease usually below here when the prominence is any significance. Here you see a narrow forehead, or frontal diameter. This is a child with Prader-Willi syndrome, with Prader-Willi syndrome. And this is present at birth, although it's often not recognized. It can be a feature, particularly of the girls who don't have the genital hypoplasia that the boys have, that would draw attention to their possible diagnosis. And you can say, well, this looks like a narrow forehead. I should put Prader-Willi in my differential. Here's another child who has frontal microcephaly with the short forehead. Remember, we use that rule 1, 2, 3. Then go all the way down to the chin. This child's a little bit different because some patients with microcephaly, the front suture in front of the anterior fontanelle fuses. This is the myotopic suture, and you'll get a little ridging. But still, you can see the volume of the head is still markedly reduced, particularly anteriorly. This child has holoprosencephaly, by the way. We'll talk about that in the future slides. The eyes, of all the structures of the face, the eyes tend to be the most beautiful and the most informative and the most misdiagnosed. So that you need to have a good idea of what you're seeing and why it's there, particularly if you suspect some abnormalities. We're interested in the slant of the eyes, upward or downward, the spacing, the distance between the pupils, the size of the eyes as measured by the cornea, and the prominence and recession of the eyes when present, whether, what the eyelashes and eyebrows look like, including the eyelids. We're interested in the external portions of the eyes for the purpose of this talk, which would include corneas, irides, and pupils. And then the palpebral fissures, the distance from the medial corner of the eye to the lateral corner. Here's a boy with Crouzon Syndrome, which involves short stature, webbed neck, which we'll talk about later, who clearly looks as if he has wide-spaced eyes. There are measurements for this that you can use a tape measure, and you would measure from the middle of the pupil to the opposite eye, middle of the pupil, and that has about a 95% accuracy. You don't need any special things, and you can carry it on your person and use it. Most individuals with wide-spaced eyes are either normal slant or even more common downward slanted, as you see in this child. That's downward slanted from the medial canthus here to the lateral canthus there. The more the slant is, the more the upper lid looks like it's covering the pupil, and so you sometimes will suspect that there's some ptosis or dropping of the upper lid. Those individuals who have closely spaced eyes, as does this child who has holoprosencephaly, their eyes usually slant upward. Not always, but usually. This child has holoprosencephaly, and the anterior portion of the brain is primarily involved here and is decreased in volume, so you have the short forehead, the decreased volume of the forehead, and the eyes up slant. And you also see the secondary effects of holoprosencephaly with lack of nasal development, no nares, and often a cleft. This child has Rubinstein-Taybi, the broad thumbs, broad toes syndrome with hypertrichosis, and most of them had mild degree of down-slanted eyes and hypertelorism. Here's a child with Down syndrome. The eyes look like they're widely spaced to a lot of people because there's epicanthal folds here that obstruct the whites of the medial portions of the conjunctiva. So that gives you the false impression that they're wide. But a good indication, besides measuring, is that the eyes are upslanted. And when you measure these eyes, they are close together. And when you take an x-ray of the face, the bones that form the orbits in the medial portions are also close together. I can stop and talk about each of these cases and give the whole talk based on them. We've got better pictures to do that. Here's an individual who has Burke Syndrome, type 1, hypertelorism. These eyes are widely spaced. Keep doing it. And the medial canthi that should be there and there are moved outward, so you don't see much white between the eyes. So this is one of the few examples of someone who's hyperteluric, who has wide space, whose eyes look wide spaced, but in type 2, they only have this is called dystopia canthorum, they only have dystopia canthorum and not hypertelorism, yet they still look like they have true hypertelorism. That's called telancanthus. This is an adult with Wardenburg's, and it's of interest is that as these individuals get older, their dystopia becomes less and less. And so often in adulthood, they'll be left with wide-spaced eyes, but no dystopia. So looking at earlier pictures of her when she was young would identify that she did in fact have dystopia canthorum. Here's some other individuals with Wardenburg's, a white forelock, often very common. You can see that she has a hearing loss as well. She has some upslants to her eyes. They don't look particularly wide spaced, but that she is Oriental, so that may impact how you look at her features. Here's a girl who has type 2. She looks hypertoleric, but she's not. The measurement from here to here is normal, but she has dystopia cantorum. So it looks like this area is increased in space and gives the eyes the appearance of hypertelorism. All of you know the banjo player from Deliverance. He has the blepharophimosis syndrome with the short palpebral fissures, the secondary but not true ptosis, laterally protruding ears, and a full nasal tip. The eyes are artificially ptotic because they're pulled, the lids are pulled down because there's not as much space for them to expand. But he can raise his lids and doesn't have true ptosis. This girl has pseudotosis because she has lack of development of the malar bones here and here. The malar bones support the lower portion of the lower eyelid. So when it's not formed normally, frequently it droops. And often in this syndrome, Treacher Collins, they'll have a cleft right here in the lower lid on the lateral side. They have a high nasal bridge, and in some cases it looks fairly tubular as you go down. This is a child with Smith-Lemli-Opitz who has normal palpebral fissure length, but has true ptosis. So this child cannot raise his upper eyelids. Here's a child who has a form of craniosynostosis with prominence of the eyes, so that the eyes protrude further out because the orbits in which the eye is set are reduced in size. So there's not enough room for the eye, and it gets pushed forward. It helps with diagnosis. Sometimes there's suspicion of a shallow orbits. It also has a complication of compression of the optic nerve, so some of these individuals can actually have reduced vision and simultaneous blindness. This child has no eyes. What you're seeing here is very poorly developed palpebral fissures and eyelids, because they require the eye to develop its normal size for it to develop. What is present is are little residual cysts of the eyes where the eyes did not form. So the little protrusions here are not ocular as far as the eyes are concerned. Here's a mother and her child with Crouzon Syndrome, a cranial synostosis syndrome in which there's not limb abnormalities. And I want to show you some things to show you why it's important to look at pictures. You see the child with Crouzon's, his nasal bridge is pseudo-flat, but it's not high like his mother's. If you were to look at his mother's picture when she was the same age, it would look like this. Also note that the nose looked placed fairly high on the face, and in her it does not. So with growth or lack of growth, these relationships change with age, so it's always good to be aware of that. Here you can see another unrelated woman with Crouzon's who has the high nasal bridge. What we see with flat nasal bridges in a young infant is as you grow older and the nose finally comes out, it's often narrowed at its base. You see that over and over again. These acne lesions are not uncommon in Crouzon's, by the way. Here's a child with Burke Syndrome with acrocephaly, a high forehead that didn't mean to be high, but the sutures that line the head here would not let it grow out. It forced the brain to grow up. So you have a high forehead as a secondary effect of the sutures being fused early in fetal development. You can see the mitten syndactyly that is present. There's similar involvement of the feet. She's had surgery to separate the fingers with some success. The eyes can be fused, cyclopia. There's varying degrees of this, but the common factor is there's only one eye and it's central. And that affects the entire face. It causes the nose to not develop normally or not develop at all. It causes the filter to be very simple. And then here's a good example of eye recession. It has nothing to do with the orbits. When the orbits are formed normally, the fat tissue around them it isn't as well developed in these syndromes I'm going to show you. And sometimes when the children are born blind, and the eyes have a searching movement, but constant nystagmus. And this takes up energy and uses up the fat resources in the orbit, so that the eyes look recessed and are recessed because there's no fat tissue around them to give them the normal prominence. This is a child who also has a very rare syndrome, Lowe syndrome, oculocerebral syndrome, and this is typical for them. They also often have large corneas because they have glaucoma. When you have large corneas, and you can measure corneas from 3 o'clock to 9 o'clock, and they're normal sizes for that, about 10 to 12 millimeters, and anything more than that, it means that the cornea is large, and the most common cause for the cornea to be large is glaucoma, which is treatable in some instances and others not, because in this condition, the corneas have been abnormal in utero for many months. Here's a girl who has very prominent nasal tip, beady eyes. You can see if we measure her corneas would be about 6 millimeters across, not the 10 to 12 that they should be. And she also has, if she were to open her mouth, she has abnormally formed teeth. And this is oculodentodigital syndrome. And their nose is very typical. Their eyes are small, but usually do not have structural abnormalities. Not always, but usually. Now here's a child who has a small eye, because there's a coloboma there. There's a lack of fusion of the eye at 6 o'clock. And that occurs early in the pregnancy, and most people who have colobomas will have reduced size of the eyes, some fairly severe, some moderate, some mild. And she has an abnormal eye here for other reasons. She has the Crouzon Syndrome. Here is another child with Lowe syndrome. Again, see the large corneas. Here's a child with a 3q deletion duplication who has large corneas. This child has large corneas. A lot of people think these are cute and look like baby doll eyes. Sometimes they're cute and not a problem. Sometimes they're cute and they are a problem. And this child certainly has glaucoma and required surgical intervention. The nose size is important both at the bridge and at the tip. Placement, where the nose is on the face, and you think, well, it's always the same place. Well, it's not always at the same place, and we'll show you that. The configuration can be very useful in regards to suspecting particular conditions. We'll divide the bridge up into the upper 1/3, and then the middle part of the nose will be the middle 1/3 of the nose, and the tip of the nose will be the lower 1/3. And we'll use certain descriptors to deal with these. But in certain syndromes, the nose is very classic and can make you think of a syndrome diagnosis immediately when you see it. And to mean there's not a differential, but you've lowered your differential from 100 to 3. Here's a normal boy. I did see normal patients in my practice, although they're all interesting, normal or otherwise. The upper 1/3 is defined as that area of the nose that is raised and in between the eyes. The middle 1/3 is that area from that upper 1/3 down to the soft tissue part. So this forms mostly cartilage. And you can sort of figure that a lot of conditions that involve bone abnormalities, particularly cartilage defects, are going to have the middle 1/3 underdeveloped or abnormal. And then the lower 1/3 is the fleshy part. Now, how could this be of interest? Well, look here. A child with the Lang syndrome who has a nose that is set high on the face. There's the lower 1/3 is present, and there's no middle 1/3, and then there is the upper 1/3. This is a consistent feature of this syndrome. If you're thinking about this syndrome, except in its very mildest forms, and you don't see this, the patient does not have the Lang syndrome. Might as well show you this as we go through. Because the nose is high set on the face, this area between the nose and upper lip is longer. So it's a long filtrum in conditions that the nose is high set. as an unrelated phenomenon, these children always have a thin upper lip with the mouth corners downturned. Here's a boy with Williams syndrome, and the Williams children, when they're young, this boy's a teenager, have a high set nose as well. Again, he still hasn't shown good development of the middle 1/3, but he has the upper 1/3 and the lower 1/3. And also note that he has a long filtrum. This is, again, a consistent feature, so that it is useful. I'll draw attention to the fact that he also has large lips and large mouth and everted lower lip to cover some of the oral, not oral, but the mouth features I'll show later with other syndromes. Now here's a child who has Hallermann-Streiff syndrome, a very rare condition with hypocreases of the scalp, with high frequency of cataracts and secondary mycophthalmia, even blindness. Very tiny nose. Look at that, very tiny. It does have a lower 1/3 and a middle 1/3 and upper 1/3, but the whole face is tiny, so that isn't particularly helpful. We'll see an older individual with this condition in a few minutes. Here's a pear-shaped nose. Look how thick it is. And also, I want to draw attention to the ali are clefted here. And this is an individual with Gideon Syndrome, which is closely related to the trichorhinophalangeal syndrome. And this is a classic nose for that syndrome. There are very few syndromes that actually have noses like this. Then you see this condition in which the nares are widely spaced. There's a cleft of the middle portion of the nose and accentuated crevice in the filtrum here. This is a child, and also the eyes are widely spaced. This is a child with frontonasal dysplasia. And we'll show you how variable this can be in regards to the nose and the face, and the filtrum and the mouth. Here is a collage of 4 different individuals with frontonasal dysplasia. This child would be a hard call. The only suggestion is that he has mild hypertelorism. See the white mark here? That's a central defect that you can actually see in normal people. But in patients with frontonasal dysplasia of the mild form, that may be the first indication that that's what this child has. And then you see an individual with frontonasal dysplasia who has wide-spaced eyes that are not in question. You can see that there's a cataract here. You can see that he's also had a repair of his cleft lip and palate. Here's another child with frontonasal dysplasia with hypertelorism, elevated nares on this side. This individual may or may not have frontonasal dysplasia because the nares is usually not elevated like this, particularly so unilaterally, but he was initially put into that category. Here's a child who has severe hypertelorism. Can't hardly even see the eye on the right side. And widely spaced nares and a huge cleft. You can bet that this individual is not going to be intellectually normal. And this boy would run an increased risk of having intellectual problems and/or seizures and an anterior brain abnormality or a encephalocele here, which is sometimes found in these children in the anterior part of the skull. Here's another patient with Optical Digital Syndrome and that very pointed nose and the small eyes. The redness is because of whooping cough. She coughed so much that she had hemorrhage on her sclera, so that's got nothing to do with the picture. You can see that she has short 4th and 5th fingers, and both of these 4th and 5th fingers were fused at birth, one of the more unique features of this syndrome, and have been separated. Here's a lateral of one of the patients with cranial synostosis. I believe this guy has Crouzon's, and you can see the beak nose, very high. Remember, at one time it was relatively flat, and over time it's changed. And it's accentuated here because they have maxillary flattening here. And we'll see some more patients with maxillary flattening that can affect the nasal development as well. Here's a Rubinstein tabby. You can see the broad thumbs on this individual who has the high nasal bridge, not particularly down-slanted eyes. Here's a child who's about 10 or 11 who has acrodyssostosis, and they have very flat upper mid-face. When you see these children on a lateral view, they will look very flat. There won't be much prominence at all. Bruce 9-TB, this boy has a little bit of beaking. This is where the beaking usually occurs in the middle 1/3. And the bigger the nose, the more often there is beaking as far as the nose being big in the upper, middle, and lower 1/3. Here's a Haldeman strife adult. See the sparse hair? Remember the child with the very small nasal tip? Well, the nasal tip has gotten bigger, and he has now formed a bulge at the middle 1/3, so-called beak nose, which happens even in the presence of very small nasal configuration. Here's another child with Crouzon's who's got this mid-facial flattening, which causes the bridge of the nose to go at a sharper angle into the glabella here, the lower portion of the forehead. This child has pfeiffers. Again, the nose, the lower 1/3 is well developed. There's not a defined middle 1/3 at this point, and all you have is an abbreviated area for the upper 1/3. This boy has an interesting story that I'll tell you briefly. I went to see him at the medicine ward. He'd been admitted for a fractured jaw, and I was talking to him because he could not see. And I said, well, what happened? He said, well, I was riding my four-wheeler and I had a wreck. I said, what are you doing? He said, well, doctor, it was dark. I said, well, you can't see. It was dark. What were you out there doing that? He said, Doc, I was drunk. So, he's trying to be as normal as possible. He's going to kill himself, but nevertheless. This child has velocardiofacial syndrome. They have a very tubular type of nose. The tip, as they get older, becomes prominent, but in the young infant with this, it's flat, actually pushed back. But that changes over time. Here's a child with Bryan syndrome, congenital facial palsy, that started in utero, so that there's no crease development. The mouth can't hold itself in its normal position, let's say horizontal, so it looks triangular. And it affects the configuration of the nose. Again, sort of tubular, like this young lady's, but on a totally different basis. Here's a Noonan's who has some nasal obstruction and has an open mouth to breathe better. Here's a Crouzon's. Look, it's still the 1/3 here, and the upper 1/3, the middle 1/3 hasn't developed, which it will do over time and probably become beaked. These individuals, as you will see, sometimes have to keep their mouth open to breathe better because they have compression of the nasal passages, and some of them are going to have Treacher or stenosis due to that. The child here has a very bulky nose, not only at the tip, but also all the way up. He has very small underdeveloped eyes that are upslanted. This is a trisomy 13 child. And of all the features that have 100% frequency, this is the only one actually that has 100% frequency, is the bulky nose. The eye problems, the other problems, the polydactyly, the heart problems, rarely exceed 60 to 70% frequency. But in these kids, it's very thick and bulky. You've seen this picture before. I show you this. This is a child who has, a young man, who has mental retardation and a very bulky nose, but we can never relate it to his mental retardation. But I do want to show you that little things sometimes are useful. Look how short his forehead is. Use the 1/3 rule. You wouldn't even come close to getting down to his chin. Look at these creases. You know what that is? Those are folds of skin. Sometimes when you get microcephaly, it doesn't stretch the scalp out. So the skin on the scalp can fold. And it can be much more dramatic than this. So pay attention to the minutiae of the patient's features. The detective, Sherlock Holmes, he always paid attention to what he called trifles. He's told his colleagues that that's why I'm a better detective than anybody else. Because most of us can see the large things, it's the subtle things that lead us to the final diagnosis. We talked a little bit about malar maxillary development. There is a number of conditions in which the whole mid-face is hypoplastic. I personally need to have the nose to be hypoplastic too, but that's not the way the literature works. And I'll show you some examples of both. Malar hypoplasia is the area below the eyes down to the corners of the mouth and around. And then maxillary excuse me, did I say malar? That's the area here, the cheekbones, the juncture laterally. And the maxillary bone is this bone here. And they can vary not only in width, but in prominence. All these individuals are said to have hypoplasia, and the proof of the pudding is that when you turn them sideways and look laterally, there's very little protrusion of the facial structures. So that means that the nose is hypoplastic, that the malar bones are hypoplastic, that the maxillary bones are hypoplastic, and that's true mid-facial hypoplasia. Now, as some of these individuals get older, this girl here, her nose is going to grow out. So she's going to have this area flat, but her nose will grow out and it will not then be flat. So she'll look a little bit different than she looks now. These collages are of different patients who have Treacher Syndrome. And here's a child who would be a very difficult call if one of the parents wasn't having Treacher Syndrome, because the eyes show very minimal abnormalities in regards to the down slant. The lower lid is not cleft, and this individual's nasal bridge is already high. Now here is a child who shows the features that this child doesn't, and he has a grandfather who shows them more extensively. See how flat his bridge is, the nose is now? Look at his grandfather's. Remember I said when a flat nasal bridge grows out into adulthood, it's usually very narrow. So that's always an indication when you're looking at the parents, and you're trying to match them up with a child, that you say, well, their nose isn't flat. Well, depending on the syndrome, it may have been flat at one time. Then here's a more severely affected child. You can see the down slant of the eyes. And here's one of the more seriously affected children with Treacher Collins. It's also associated with deafness, and there's almost no development of the malar bones. The maxillary bones are hypoplastic as well. The mandible is hypoplastic. The nasal bridge, however, is high at this age. There's usually a cleft right here, where the sharpest angle of the lower lid is, and that is not caused by the angle, but is congenital, programmed that way. Here's a child who has no philtrum. Here's a child who has a long philtrum, Gideon Syndrome again. This is a child with Wolff-Hirschhorn 4P deletion syndrome, 1-3 I believe, and they rarely have much in the way of a developed philtrum, and if it's present, it's usually short. Remember the trisomy 13 I showed you before? This is a different one. Look at the nose. He has no eye development. You know this because there's no lid development here. And you can see that he has poorly developed philtrum. It's very simple, which is also another feature, but also indicates the high frequency of holoprosencephaly in this condition. Here's a child who has has trichorhinophalangeal syndrome. It's a companion to the Gideon syndrome, but they have limb abnormalities where the Gideons do not. And you can see the bulbous nose he has. Here's a girl who has iris dysplasia or mesodermal dysgenesis of the iris, so they have visual issues. They also have, if she could open her mouth, enamel hypoplasia of the teeth, and their philtrum is very, very short. She has a normal length nose, but the philtrum tends to be short in these individuals. The mouth, we talk about the size. We're interested in the shape and corners of the mouth, i.e. the contour. The lips, whether they're large, thin, everted, and there are many other descriptors, and whether there are pits, and we're talking about, and the lips in particular, whether the lower lip is retracted or everted. There are many other descriptors that I could put into these things, but these are the more common ones that you pay attention to. One of the things about trisomy 18 patients, which is what this child had, is that the face is small, facial bone structure is small, the mouth is small, the belly is small, the nose is usually small as well, and of course the forehead can be short. It doesn't look that way, particularly here. And then you can think about the mouth in Beckwith-Wiedemann, which is what this child has and what this child has. That's an overgrowth syndrome with omphalocele and a number of other features. And because of the large tongue in utero, the mouth is large. If the tongue is not large, usually you don't get a large mouth. And some of these individuals don't have a large mouth or macroglossia, but most are going to have varying degrees of it. Remember the Langer-Gideon, the Cornelia-Lang patient I showed you? Look how high set the nose is. And look at the thin upper lip and downturned corners of the mouth. So you should be getting the impression that these features are repetitive, that they're useful, and that they're not commonly found in normals. But the variability of normals is such that they are sometimes found in normals, and you have to look at the parents and the family background to make a judgment about that. One thing we see here, a high forehead, narrow bifrontal diameter, and what you wouldn't pay attention to because the nose looks pretty normal, the philtrum looks pretty normal, is this crease here, this retraction. The mouth gets its protrusion because there are teeth, buds in the gums. If there's no teeth, the gums retract like an older person who's lost all their teeth, and that shows up in the form of a retracted mouth and often retraction of the lip, particularly the lower lip. This child has aglossia, adactylia, is missing part of the tongue, and has a very poorly developed gingiva. They're very flat. There's almost no teeth in them. Here's a child who has, a young man who has a large mouth, has a triangular face. We'll talk about the face overall in a few minutes, but the mouth has a lot of little tumors in it. These little tumors are involving the thyroid as well, and they can have pheochromocytomas of the adrenal gland. And so when you see someone, and they can look like Marfan syndrome because they're generally tall and thin. And when you see a Marfan syndrome who has a mouth like this, it's not Marfan syndrome. It's this syndrome. Here's an individual who's had a repaired cleft lip and has these little indentations in the lower lip. These are lip pits. And the lip pits can be fairly subtle. I've missed them before. Not looking for them, but not being careful in my examination of the lips, thinking the patient that I saw had something else, and only finding them later. So they're not all as gross as this. Some are actually larger. Lip pit Treacher syndrome is one of the 3 syndromes that have lip pits, and they can be very dramatic or very mild. Here's a child who has craniosynostosis with Apert syndrome, and he keeps his mouth open all the time because his nasal passages are not open enough for him to breathe comfortably. Sometimes, remember we talked about the teeth being absent, the gingiva would retract, be hypoplastic. Well, what if there's fibrous tissue in the gingiva? What happens? Well, this is a fibrous dysplasia of the gums, and it causes the mouth to protrude, and often these individuals will have an enlarged mouth. And this is a very rare condition. They have hypertrichosis, thick eyebrows and eyelashes, and a number of other features, but it's this feature that draws the earliest attention to the thickening of the gingiva, and then, of course, the medical issues of seizures and sometimes mental retardation. Here's an individual whose mouth has a midline indentation. This is often misconstrued to be a cleft of the midline, which does occur, but this is usually because the frenuli under here that attaches the upper part of the lip, underside to the lip, is tight, and it pulls this up. And it's found in a number of conditions, including Ellis and Crouzon Syndrome, an orphan condition, and oral facial digital syndrome. Then you have a mouth that's sucked in, or puckered, a little of both. This individual you can see has decreased muscle mass, very thin-looking chest, and cannot release the mouth to be open and move appropriately. And this is what the mouth looks like when it's always in contraction or myotonic. This is the whistling face syndrome, and they often, because it's a chronic problem for them, they often have this ridge of tissue that goes up from the chin to the lower lip. The mandible, probably the least useful feature of all the ones we talked about, but the mandible is something that everybody looks at and pays great attention to, but it's not as useful as a lot of the other features because, first of all, it's very obvious. If it's big or small, there's usually not a big argument over that, although I can give you some examples where there is. We're interested in the size, the prominence, and we talk about prominence in a term prognatic, but it can be overgrown and prognatic. The hyperplasia can be localized to one side or the other, and then the width is affected. If this is on both sides, not just one side, the width is going to be wide, and I'll show you an example of that. And of course, we're interested in symmetry. This boy has a prognatic mandible. And the prognatic mandible simply means that it's a mandible that is protruding more than it should. And as children get older, particularly males, their mandible tends to get larger, quicker, and to a more significant degree, so that their mandible, by the time they're adults, can look mildly prognatic just on the basis of growth and testosterone effect. Here's a condition. This mother had this condition. She looks fine now. The unaffected brother looks fine, but see the full jaw here? This is fibrous dysplasia of the mandible, and it usually starts either late in uterine development or during early postnatal development, and it continues to get worse for a period of time, a variable period of time, and eventually it stops. For the most part, these individuals are not going to have any major difficulties with their mandible being prognatic, so it's not a cosmetic problem for them. Here's a child who has enlargement of the mandible all over. You first have to rule out mumps. And as you know, mumps is coming back into vogue because of the lack of immunizations. And so after you've ruled out mumps, obviously palpation, you could have done this the first time before you had to rule out mumps. You can feel the enlargement. The bone's large, firm, sometimes irregular. This is Caffey's disease. That can be in utero or post utero. And generally speaking, over a period of time, it will get better and go away. Sometimes, however, it doesn't, and sometimes it involves the orbits. You can have compression of the optic nerve and visual difficulties as well. So you need to know what to look for with this condition. This is the classic Pierre-Robin syndrome. Pierre and Robin is the same person. Everybody wants to put a dash between the two, but they're different Frenchmen. And they reported this with very small mandible so that it would not hold the tongue up during intrauterine development. And cleft would occur, and then the ears would be low set. But there's many, many, many descriptors of syndromes as Pierre-Robin with this and that and that. I don't use the term Pierre-Robin except for this condition. If they have anything else, then you've got a more extensive syndrome. The importance here is that the mandible will grow back out. Most congenitally small mandibles will not grow back out. But here it does. They're intellectually normal. So it's important to have the right diagnosis early in this individual's life. Ears, placement, protrusion, size, globules, helices, tags, pits, cysts. There are books on the ears that would tell you that there's lots of different ears. The degree of variability among normals is dramatic. And so until you looked at all the family members, and that doesn't mean that it's not abnormal. You can have abnormal family members as well. But when you look at them and they're otherwise normal, this may be familial or it could be part of a syndrome that the family has. ears that are low set. If you close your eyelids and draw a line along them, the ears should intersect that line. Here you can see if you do that, the line's up here. Well, this child has hydrocephalus. And when you have congenital hydrocephalus, the ears, which start down here and migrate up, they can't come up to their normal position. So all children, at least the young children with hydrocephalus, are going to have low-set ears. So the low-set ears in this particular condition have nothing to do with the rest of the child's problems. Low-set ears were used as a descriptor from the get-go because it was so visible to everybody, and they become even less useful overall than the mandible, although there are exceptions. Here's not only low-set ears, this ear is normally formed, but he has poorly formed spear helix. He has little hydrocephalus, and the ear is angled. It's not only low, it's angled posteriorly. This one's fairly well placed, but this one, the vertical line here would be posteriorly. Here's a child with Smith-Lemley-Opitz. They always have low-set ears, but looky there, they always have a small mandible as well to explain the low-set ears. They also have abnormally formed ears. You can see there's decreased cartilage here and abnormal cartilage in the lobule. Here's a girl who has abnormal ear, over down superior helix, it's retroverted. She has a syndrome that you've heard about before with hypertrichosis of the elbows and knees, and also she had hair on the anterior portion of her throat. The hairy throat syndrome is a variation of the syndrome of the hairy elbows and knees. Preauricular tags and pits. This is a, let's see, you can't see that too well, but there is a pit there in the helix. There's a pit here in front of the helix. There's a pit here in the helix. These are helical pits. 5% of the normal population have these. So by themselves, they don't mean anything. If the ear's abnormally formed, this is sort of plus minus in its formation, but in this particular situation, the cartilage is deficient. The chances of there being abnormalities within the ear itself that affects hearing goes up. If you have the preauricular tags and pits and the malformed ear, then you need to test these individuals' hearing very carefully, and not just on the side that's abnormal. Sometimes these type of features only occur on one side. More often they occur on both sides, but one side's much less involved, and so that's often passed off as being normal. Sometimes there's an attempt immunologically for a new ear to form, and when you take this off, it has cartilage that you find in the ear. This is a preauricular ear or cartilage, and the whole degree of involvement here in the form of microtia is a type 3, which is severe, but still some anatomy remains for the ear. Short palpebral fissures, hearing problems. Ears are almost always small in these individuals, so this is blepharophimosis syndrome. This lower portion of this ear is missing. This is the charge syndrome. This is the most classic feature of the charge syndrome as far as being able to look at it and say this child is at high risk of having charge. But the smallness of the ear is the most common abnormality. And they usually are as well malformed. And you have the so-called BAT ears that stick out, that sometimes stick out enough for all the individual has to have surgery. And usually these ears are deficient in cartilage, much as you see here. And sometimes this can be unilateral or bilateral. Here are earlobe creases in an affected child with Beckwith-Wiedemann syndrome and the carrier mother. This was her only feature of being a carrier. We looked at her very carefully because her sister, who had no features, had an affected son. And so we knew that this was in fact a feature that indicated she was a carrier. And her child, who is this child here, where you see the omphalocele and the large tongue, had the creases as well. Sometimes these individuals will have pits on the back part of the ear. So we always look at the back part of the ear. Unfortunately, normal people can have pits on the back of the ear, so you have to be a little bit critical of that feature until you find other supportive data. The neck gives the face a gestalt. Its length, its width, its vertical orientation, whether it has abnormalities involving clefts or webbing, and the hairline can also contribute to the gestalt of the face. Here you see an individual who actually has Gideon Syndrome, who has a webbed neck. Note that it is not short, but people interpret this as being short because the web gives you less space to look at when it attaches to the shoulders. And so even when it's not short, it's often called short. Here's a Turner's Bortus who has these large cystic fibromas that if this child had survived, which most don't with this degree of edema, these would have become these. Maybe a little bit larger, but with the fluid out of them, they contract and look like this. This is a Turner's child as well. And then here is a child who has what appears to be a short neck, but has microcephaly, and the skin's been forced down. You can see a few of the areas that have the rugae, or elevated areas. We got through on time. One of the few and only syndromes that truly has a short neck is the Clippophile syndrome. It's short, and you can see it, the neck, their head sits almost on the shoulders. And it's because there's fusion of the vertebrae here that shortens the distance from the skull and the shoulder area, or the cervical, lower cervical spine area. So when you say a person has a short neck, you better be careful, because most of the time the neck only looks short, and you have to look for things that might cause it to be look short and not short. And what's common is webbing or edema, and you can get the muscle-bound football players or the wrestlers who have no neck that you can see because it's all muscle, but the neck is not short. And then the branchiootorenal syndrome, which is associated with hearing loss, has these neck fistulae, often red in appearance. Sometimes they'll form a cyst, and sometimes they'll be open, and they can be quite subtle, so you need to look at them. And of course, look at the ears here. The cartilage is not well formed in these two individuals. I believe this is a father and son. This is a mother and son. And the branchiootofacial syndrome has a very classic face. Look at that filter, how distinctive it is. Inverted V mouth, the uplifted lobules. He also has ocular problems in the form of nystagmus and squint. But this is the most unique thing involving his face, this posterior auricular reddish lesion that looks like a birthmark, but it's in fact ectopic thymic tissue. And this is only found in this condition. And the face, we've talked about it all over. I'll just go back and show you a few things. But these are the things we're going to talk about very briefly. You have a triangular face, but it can be large triangular face, as it is in this overgrowth syndrome, Soda syndrome, or it can be small, as it is in this patient with Russell-Silver syndrome. By the way, Russell-Silver usually has a thin upper lip and a fairly long filter. And then hemangiomas can cause asymmetry, in Sturge-Weber syndrome, and Klippel-Weber and Klippel-Ferrani-Weber syndrome, and then in the linear nevus sebaceous syndrome. And then you have syndromes like the Leprechaun syndrome, in which there's congenital facial palsy. That gives you the typical Gestalt that we've already talked about and shown you the features. By the way, I missed this one in the newborn period. Focus on the wrong thing. And then here's a individual with trisomy 18 in the small face. And this is a child with hypohydrotic ectodermal dysplasia. They typically, in early infancy and childhood, have a full face with full cheeks. But as they get older, they develop reduced fat tissue and a triangular face. Pretty typical for all these. Then you have the asymmetric face, This individual's left mandible is underdeveloped. The ear's hypoplastic. This is hemifacial macrosomia. It doesn't have to be this severe. The chest involvement often isn't present. And it can be bilateral. Short neck, prominent mandible, hairy eyebrows and eyelashes in a Crouzon Syndrome patient. Here's another halamus stripe with a small nose and scalp hypotrichosis. This is a midfacial upper developmental hypoplasia, an 18q deletion girl. And here's just to show you the importance of sequence of facial photographs to make or exclude diagnoses. He had minor delays in development in this picture. Not much more in this picture, but as he's getting older, his delays, both motor and mental, were increasing. As he got older, his face started to change into something that someone could suspect is Gideon Syndrome. And by the time he's a young adult, this is what he has. Pretty classic case of Gideon. So even some of the severe conditions can look mild early and look worse later. So if you have an older individual, it's always important to get younger pictures. Okay, thank you. Hope you never look at the face again.